Hi, everyone. So across the past couple of months, we spent quite a bit of time talking with our Coalition for Health Improvement about the intersection of COVID-19 and community health. And we've centered on this topic for a couple of reasons. Number one, we know that some of the community health issues that existed before COVID-19 make us even more vulnerable to the pandemic. And on top of that, the pandemic itself makes community health issues that already exist even worse, and has the potential to create new and different community health issues that need to be addressed. So I'm going to share a graph with you all, which I'm sure is familiar to you. Many of you have seen it, and it shows the surge in cases here in Okanogan County relative to the rest of Washington state. The graph that I'm showing you comes from a COVID-19 health equity interactive dashboard. So this website also talks about some of the county characteristics that impact an individual's risk of infection of COVID-19. And they also tell us that counties with a large number of vulnerable people might be disproportionately impacted by COVID-19. So I think the tools they've created are really interesting and really informative for us as a CHI, because they help us see some of the ways in which our community was both already vulnerable to something like COVID-19 and help us think about how we in the future can better position ourselves to prevent a pandemic like COVID-19 from affecting us so severely. So some of the county characteristics that popped out to me. So 19.7% of Okanogan County's population is Hispanic, compared to 12% in Washington state as a whole. We also see that Okanogan County has a 20% poverty rate, compared to only 11% in Washington state. Okanogan County has a 14% uninsured rate, compared to only 7.5% in Washington state. We also have a substantially larger number of people who are over the age of 65, and 2.7% of our population live in group quarters, compared to only 2% of Washington state as a whole. But you all at the Okanogan Coalition for Health Improvement, you know these things. You know that if we're struggling with housing before the pandemic, and the pandemic hits, housing is actually going to become even more difficult for people. You know that if people can't afford the health insurance that they need out here, and then a pandemic hits, it's going to be even harder for them to stay safe. As a Coalition for Health Improvement, you all know these things. But we spent the last couple months doing as much as we can to better understand them and to do the work to help you all as members keep thinking about ways in which we might be able to address them. So in preparation for the second half of our Coalition for Health Improvement meeting, I'm inviting Jimmy Wallace and Nash Mendez to reflect back on some of the community health issues that we've learned more about through the Coalition for Health Improvement across the last couple of months. Hi, everyone. Thank you for joining us for this September Okanogan Coalition for Health Improvement meeting. I'm here today with Jimmy Wallace and Nash Mendez. Jimmy, why don't I let you introduce yourself, and then we'll talk a little bit about what we're doing, and Nancy, you can go right after Jimmy.
Sure. Hey, everybody. I'm Jimmy Wallace. I'm the medical director of Family Health Centers. Work as a primary care physician, a family physician throughout Okanogan County, mostly in Brewster and Twisp. Also get to work at Three Rivers Hospital and Mid-Valley Hospital, and play a role in supporting all the healthcare providers as well as clinical services for family health centers. Enjoy interacting with all the different communities throughout the county. And as we broaden our scope and recognize that social determinants of health are so essential in providing care to our patients and communities, have really enjoyed reaching out and working with all of the partners throughout the community and organizations that are also focusing on keeping the county healthy and thriving, and trying to fill in the gaps where services are needed.
I am Nash Mendez. I'm the Executive Director of the Housing Authority of Okanogan County, your Housing Authority of Okanogan County. Our mission is to connect community members with who are in needed housing with housing. And also our broader umbrella is to be an intricate part of being a solution, bringing a solution to the various social determinants of health. And as we all know, housing is a big part of bringing the equilibrium to the social determinants of health. And we're here to serve you And we are very, very happy to be part of this conversation today.
Gotcha. So as our tribe members know, for the last 4 months, we've been talking a lot about COVID-19 and how it's affecting different community health issues. And we have covered a lot of different topics, from wildfires and COVID and how those two things come together, to housing access, to mental health, to the effects of school closures. And what I asked Jimmy and Nancy to come and join me to do today is to reflect on some of those key community health issues that we've talked about across the last 4 months. The first one that I have on our list here is food access. So we heard early on in our CHI meetings that there was a sharp rise in the number of people who were seeking food support, including folks who had never used food banks before. Nancy or Jimmy, could you tell me a little bit more about how COVID-19 might affect access to food and which populations might be most affected?
Elana, I would like to start out with a short story, and maybe Jimmy can augment what I said. On my way to work, the Housing Authority, on a daily basis, I drive by the food bank, the OMAC food bank. And I have been doing this for years, of course. What really was the increase of numbers waiting in the parking lot, the amount of cars and people without cars waiting for the food pantry or the food bank to open. Mm-hmm. And some people are out there very early in the morning, think about 6, 7 in the morning. And I'm right now, for example, even getting a little chiller in the mornings, and I begin to worry. The number of people waiting for the food bank to open to get their supplies has increased just from my eyes as a passerby. I know that during the summer months, it was perhaps comfortable to wait on that parking lot. I worried about these people during the fires. Mm-hmm. In fact, I personally purchased some masks and stopped by the parking lot and hand out some masks to the people who did not have masks as they were waiting for the food pantry to open. But also I'm beginning to think, as a community member, I'm beginning to think, what will happen to these people? How will they wait during the harshness of our winter months? Mm-hmm. Jimmy, what have you heard or seen?
One thing that really hit home for me was that when our schools closed, many families lost a primary source of nutrition for their children. That one of the most essential roles schools so often play is providing that lunch and oftentimes breakfast and an afternoon snack for kids. And families really were finding themselves in a state of hardship or increasing hardship because those options weren't available. And I'm so impressed with the way so many school districts in our county responded to that and continued to provide meals and but I think it made it even more clear to me how pervasive and widespread food insecurity is across our county. And an economic hit like COVID, an economic hit like the wildfires just puts that population at so much greater risk.
You know, I think that's a nice, I would say just a spot on way for us to talk about one of the other community health issues that we spent some time on in the last CHI meetings. I think it was the CHI meeting in August, and that was the effect of school closures on community health. Yeah. And some of the pieces we heard, just reflect back, and then I'll turn the virtual microphone back over to you both, was that in the Latinx community and the young people community in general, there's a low trust in telehealth, which is one of the primary service access strategies for quite a few health clinics, mental health resources. Limited internet access. We heard from Brewster that almost half of the families didn't have access to reliable internet. We heard from Pascal Sherman Indian School a concern about an increasing achievement gap and uh, limited access to not just food, which you mentioned, Jimmy. I think a lot of young people rely on their school to get food, but also limited access to healthcare because they were no longer going to see the school nurse. And I think this is just an interesting note, but both school districts talked about the gap in getting access to glasses and optometry, which was really interesting. So I wonder, Nancy and Jimmy, if you have any reflections on how school closures because of COVID-19 might have or has had additional layers on community health here in Okanogan County.
Yeah, I think just building off of what I guess embarrassingly came to realize is an essential role of schools, because I'm sure there are many people that have acknowledged that for a long time. That, our schools are pillars of our communities, and it's such a big part of the life of our young people that are attending schools and the families whose children are attending schools. But so much of community life revolves around the schools. And when that gets shut down, it leaves a huge gap in the lives of so many people. And we find ourselves, in crisis trying to replace, what kids do with their time, or the meals that kids are accustomed to having, or access to glasses, or access to a nurse, access to a behavioral health counselor. And I think we still have school closures, and as we begin to open more and more schools, the reality that some then might have to close again, and continue to build partnerships with schools, because one of the most beautiful things I've seen arise out of this is partnership between schools and behavioral health organizations, schools and clinical organizations, and sharing of ideas and resources and acknowledged overlaps in services. And I think it's a great template for work within the CHI, and recognizing where our overlaps in our services are, and how we can collaborate and have synergy in those areas, and then identify gaps as well, and recognize where our community is needing us to step up in more ways and provide a better service. I'm sure Nancy has good input and insight on this as well.
I also ponder about the big monumental role we're asking these parents to do to home kids, while some parents may not have the know-how, the intellectual capacity, or perhaps who has forgotten, has been in school too. And how do we come together as community members? And what is the role of the CHI in engaging community members who may come in alongside with these students who do not have the support at home, or who the parents who are both working and whose employers cannot give them the opportunity to work from home? How can we together as a community come in and support? We are living under a pandemic. We need to find ways to redefine how we do community and how we nurture and care our most vulnerable, who are our children.
Yeah, as an employer, Family Health Centers with close to 250 employees, we did a survey a few weeks ago about the impact of school closures on our workforce, and over 50% have been or will be affected, and will have to miss work because of the school closures, and are stressed about that, are torn between oftentimes as healthcare providers working on the front lines and serving the population amidst this crisis, but also taking care of their kids at home. And it's just such a crux and challenge. And from a infection control epidemiological perspective, it's dangerous to send kids back to school. The preschool that my kids attend is a petri dish, and and sharing of mild viruses and germs is just a part of it. But when we throw in something that can be more catastrophic, especially to vulnerable populations. We've really got to be careful about that. And I've appreciated seeing like a lot of the plans that schools have in place, and love the conscientious effort schools are making to open safely when they do open, and to be very, very careful about screening and distancing and masking, and being very conscientious about that. But Nancy, back to your point, it all is rooted in the social realities that our patients face. And again, those who struggle the hardest to support their children and balance that crucial values of work and childcare are really finding themselves in a crisis situation here.
I think that's a helpful way for us to talk about another issue that I know we talked about relatively lightly at the CHI meeting, but DCYF, the Department of Children, Youth, and Family, came on a couple months ago and talked about the fact that intakes for child abuse and neglect were actually decreasing, but their perception is that child abuse and neglect is not. And of course, I hear both of you reflecting that families are stressed, kids don't have access to their safety net at schools. So I wonder if one of you might give a little bit of community context for why there would be a decrease in intakes at a time like this, and the perception that child abuse and neglect is actually not going down.
We've seen a decrease in a lot of our services as an organization providing clinical services, and that's, I think, because people are scared of going to a building where people might be sick, or people that they don't know might be there, and they aren't sure of their exposure risk in accessing those services. I could see that people are making similar decisions about child abuse and neglect, and that might be a reason for intakes decreasing. I think similarly, we're seeing exacerbations of chronic disease that you think would prompt an intake into a healthcare facility or a visit with your doctor, but people are foregoing that care, and illnesses are getting worse at home while people try to maintain their health alone without the resources. And so I think we're seeing the same with domestic violence, child abuse, neglect, and all compounded by the tremendous that we're all under. And that's impacting, I think, the safety and security of children.
One of the things we heard early on too is that many of the referrals for child abuse and neglect come from the school system and often come from healthcare providers. So when I hear you say, Jimmy, that folks are choosing to see their providers with less frequency, and we know that school teachers and counselors are just not getting their eyes on kids in the same way that they used to, it makes sense that those referrals start to go down. Certainly there's a lot of dominoes that fall when kids don't get connected to the resources they need in those times of crisis. One of the things I heard you just talk about, Jimmy, was about healthcare access. And we talked about this early on. The dog's barking in the background here. As we talked about COVID and community health. One of the things we heard from the hospitals, so Mid-Valley Hospital, Three Rivers Hospitals, North Valley, and some from family health centers, was that the nationwide data showed that people were delaying care while their conditions were getting worse. And Jimmy, I heard you say, maybe that's connected to some concern about going into a public space or increasing exposure to COVID. Any other thoughts or reflections on healthcare access that might be useful for the CHI to know about in terms of COVID-19 and community health?
Yeah, I'm so impressed with how quickly the healthcare system responded on all levels. And in our clinic organizations, we had talked and dreamed about telehealth for decades as a new technology that was just so far out of reach because of technological challenges, but also because of regulatory structures And that was all lifted, and within just a few weeks, we were all up and running with video visits and phone visits, and providing people with a safer alternative to in-person visits. And that very often was appropriate. And we thought that would last for 2 or 3 months. And here we are 6 months later, still encouraging a lot of video visits. And, we've written and revised guidelines about who should or shouldn't be coming in for in-person visits. And one of the first things we wanted to delay was the routine care, the wellness visits, and the follow-up for patients with chronic disease. And that's all well and good for a couple months, but you can't let the most vulnerable patients fall off the radar. And so we've had to put a lot of effort and investment into more proactive forms of care, where we do case management, care coordination, running lists of the sickest or most vulnerable patients for one reason or another, and trying to track them down if they haven't been seen in a while, or just make a phone call and check in and make sure they're doing well. But I think that approach extended to other sectors is really important. The hospitals similarly have been overwhelmed, and I'm impressed how well they've continued to chug along without some essential services, especially early on when they had to shut down surgery and procedures and their usual lifelines, and weren't having as many patients coming in, even to the emergency room sometimes. And then we're met with the surge where systems really felt like they were on the verge of being overwhelmed. The hospitals have really, each of the three have stepped up and done amazing work. They're still, on really unstable, unshaky ground because of external forces, as well as, patient volumes, staffing, and the struggle that they've, had for so many years in maintaining their services. And we've seen obstetrics drop from 2 of the 3 county hospitals in the past year, and that having an impact on who uses what hospital and volumes. And I think we're still in the middle of a hospital transition and need to continue with work that started, I think, 9 months ago or so, in saying, hey, what's the best countywide hospital system? We had great conversations about that amidst COVID. What's the best countywide system for, response to the pandemic? I think we learned a lot from that. I think we need to move forward and say, hey, how do we create a Okanogan County healthcare system that serves everyone and doesn't fragment care between hospital districts and, exhaust the resources of all, when we could cooperate and participate in a better way.
I wonder if I could pick up one, I think, really powerful thread in there, Jimmy, which is, as the healthcare system started to experience the stress, I heard you say that one of the most effective responses you all had was to be super proactive about reaching out to clients, reaching out to patients, making sure they're getting the care they need. And I know that in a couple different CHI meetings, that same call came for access to mental health resources, thinking about ways to pivot the actual resources we had to be more responsive to where people were at. And Nancy, I heard you talk really early on about housing and what it meant for you all as an organization to switch and to, I think to sort of challenge the way that you typically provided services to make sure that no one was missed at a time when housing needs were really growing. Nancy, do you want to talk just for a minute about some of the changes you've seen in housing access out here and how COVID may have affected those things? And of course, if you want to just take a little bit of time and reflect on what you all have done to make your services so much more responsive.
Absolutely. Serving the whole Okanogan County always has been a big challenge for a small housing authority like ours, small in staff at such a large area, geographical area to serve. COVID has taught us that it is very, very important to do a lot of the case management via phone and not expect people from Loomis or Grand Coulee or Masama to come into our office. And I think to all housing authorities' surprise, even HUD at the national level has provided housing authorities with tremendous waivers, such as, for example, we are required to do an annual physical inspection of the units that we are supporting with Section 8 vouchers. That has been basically set aside for a while until it's safer for our staff to come in to the units. The biggest challenge for us has been earlier on in like March, April, when we were still groomed, and the way we do business always has been in this rigid modus operandi that is set by HUD and other funders, the regulations, but having to come in like any other sector, trying to say, okay, the need is greater, how do we providing services with limited resources. Way back in May, we opened and closed the wait list. To this day, we grieve over the fact that we didn't have our community partners to help us with the referral processes for these new vouchers that we had. So now we are looking, our management team and the board of directors is looking at reopening the wait list and trying to find more creative ways in which we can do an outreach to make sure that the most vulnerable population, those who do not have access to internet or who do not have access to cell phone or phone calls, our phone lines, can still access our services. Another thing that I wanted to mention is that we have seen an increase of homeless youth with a small child or being currently pregnant. And unfortunately, like I said, we cannot help them with the voucher systems that we have, but we refer them to community partners as well. Putting a nexus between housing and school, the number of people coming in inquiring for housing and housing needs has increased tremendously in the last month for the Housing Authority. So and once again, I always think that housing is that umbrella that brings stability to the social determinants of health. We can nail and work and try to alleviate the other social determinants of health if our community members have housing.
So one of the very last pieces we talked about at the CHI meeting, and then I know we are at time as a group here, was about wildfires and COVID-19. And we knew that some of the risks, so the populations who are at high risk for COVID-19 were also some of the same populations who are at high risk of being affected by wildfire smoke. So that include people who were in housing unstable situations, who are now more inclined to have to stay inside, which increases their exposure to COVID. Mostly, I just want to reflect that back because I think it was such an important conversation in the CHI meeting and something I hope the CHI members continue to think about and reflect on. I just want to say thank you so much, Jimmy and Nancy. Honestly, I could stay here for another hour just asking you questions.
I know. I feel like we just started.
I know. It's so
and I've got my own questions now. And maybe I look forward to the dialogue that this creates within the CHI, because I think it's a strong group, and I'm always so happy following those meetings with the strong work everybody's doing and the opportunities we have to collaborate. So look forward to action.
So true.
Yeah, and as the board member of the North Central Okanogan Communities of Health, I'm always very, very pleased and proud of our local CHI. I think we're doing great work, and as always, the work has just begun. COVID and the wildfires just added another layer of intensity, perhaps. But sometimes when we are in the war, we're in the arena, that is where we find more solutions, and we are here all together. Right. And thanks for being part of our willingness to be part of being in the arena. with all of us.
Thank you both so much. I really appreciate your time. I know how valuable it is. Okay, we'll loop back around soon.